So ASV. So just, you guys all use ASV? So you've all got Hamiltons? And you all use ASV from start to finish? No. What do you mainly use it for? Or so, who uses it right at the beginning when they intubate the patient? Yep. So when you turn the ventilator on, it comes up as your default mode. Sometimes, yeah. There's no, I'm not going to say there's no right or wrong answer, just for interest, that's all. So we turn our ventilator on, that's our default. So do you use it when you're trying to wean people, or?
Yeah,
initially. Initially? Yeah, okay. So you use it more as a weaning tool?
Yeah, once they're starting to breathe quite a bit, you'll swap to pressure support for the final wean.
So you wean them on pressure support, okay.
Yeah, we go from ASV to pressure support.
Okay, all right. Cool. Good. So what is adaptive support? So if you look at the Hamilton website, there's a simulator on here, and you look at it. There's a lot of load of education thrown into it. They, on the slide, say it all started in 1983, but ASV, I think, was first marketed in '94. But it was this chap, Hewitt's, back in 1977, who talked about a mandatory minute volume, mandatory minute ventilation. And essentially ASV is a pressure control, but it's minute volume guaranteed, yeah? So if your lungs get more stiff, it just pushes up, it'll just push up the pressure a little bit, and you still get your minute volume. And it's closed loop, and the two equations which are sort of thrown in the algorithm, one is Otis, and Otis, this is a German chap from the 1950s. He described how we change our respiratory rate and tidal volume to use the least energy. And then what Mead described in the 1960s, he was also a German guy, was that the pressure that we need to generate our tidal volume, we adjust ourselves to ensure that's the least pressure. Body is a very, very clever device. If you think of like the cardiac output, so the left and right heart match each other perfectly, don't they? As if there's like a 1 mil difference and you've got a heart rate of 60, after a minute there's a 60 mil difference on both sides. This just doesn't happen. Body's very, very clever. And then, yeah, intubation to extubation. So traditional ventilation, and again, you guys will know, I started ICU in '97. We sort of aim for a certain tidal volume. And we'd either use a set volume. So if things got better or worse, the pressure would go up or down. The States use this a lot. Canada, all the trials there, they're very volume focused. UK is a little bit more, pressure focused. And then so you set a pressure, and the volume varies. I personally think this is a potential problem, and I'll go through why I think this in a bit. And then how we cycle. So from inspiration to expiration, is this after a set time, after a set volume's gone in, after a set pressure's achieved, after you got down to a certain flow rate? This is very much traditional ventilation. There's no sort of talk of minute volume in there, is there? The modern ventilator, what's it allowed us to do, and Hamilton's sort of first on the bandwagon for this, all the other companies are going to start doing this. You can with computerization, you can link pressure and volume. Yep. I think the anaesthetic department in our theatre suite have machines which do a pressure control but volume guaranteed mode, I think. So pressure control, but it guarantees the tidal volume. And computerization allows this. We run a basics course in Reading, and we get the guys on the course to breathe through this ventilator, try the different modes. You can actually tolerate it quite well as long as the pressure's on. You don't set high pressures on you. So and then we have a patient support group. I gave a lecture at that about a year ago. The guys didn't remember the ventilator. They remember the alarms, and they asked, why couldn't I speak when I'm on a ventilator? So the interactions are very good. And there's very little resistance to airflow, and the valves are very sensitive on these ventilators. So how we breathe normally, again, sorry, I've gone through this. We decide the minute volume ourselves. Our lung mechanics determine the time constants, and we get the tidal volume. So, sorry, just repeating myself here. Sorry about this. Right, so fixed pressure. So if I come along and I've got a 70 kilogram person, okay, I'm going to say their minute volume 7 litres. That's cool. I'm going to give them a tidal volume of 500 and a rate of 14. And if I set a pressure of 20, that's going to give me a tidal volume of 500. Maybe the paralysis wears off or the patient's position changes or something. The compliance falls. What you see is the tidal volume goes down. Yep. Then what happens? Blood gas is done. The doctor or the nurse sees it and increases the pressure control back up to here. So you get your 500 ml tidal volume. That's cool. Somebody then comes along and gives a bit more paralysis. And then, before you know it, your tidal volume's up here. So the Oscar trial, that was done out of Oxford. That's our local teaching hospital. And 1 in 5 patients had a tidal volume in the control group of in excess of 14 mils per kg. This is where they use pressure control mode. So, yeah, we have a problem with pressure control, fixed pressure ventilation. There's resistance to compliance changes all the time, and you will get this tidal volume moving up and down. What you actually want to do, and again, ASV is a pressure controlled volume guaranteed, as the patient gets better, so this is the peak pressure here. You see it just gets weaned down, and you get the same minute volume. Yeah? So high tidal volumes, dangerous. Low tidal volumes, your CO2 goes up. If you have a device which gives you a guaranteed minute volume and weans the pressure or increases the pressure when there's problems, why not use it? So what is ASV? It's a pressure controlled, minute volume guaranteed mode. It's fully automated closed loop, which we use in all ventilated patients. The only time you can't use it is if there's a leak in the circuit or you have a bronchopleural fistula. So if there's a cuff leak. So, and I'll tell you the reason for this is that the time constant is measured. So this is expiratory flow. And if you've got air coming out of several places, your expiratory flow is going to be inaccurate. So you'll get an inaccurate respiratory rate. So you come along, you insert the patient's height and sex, and that calculates the ideal weight. I think all ventilators in the world should have this device. They shouldn't be CE marked without it, but anyway. 100% minute volume, this is 100 mils per kg of ideal body weight, so 70 kilogram person is 7 litres, and then your minute volume is your respiratory rate times tidal volume. So the respiratory rate is calculated from the expiratory time constant, and your tidal volume is automatically adjusted. So the expiratory time constant is measured in seconds. So a normal expiratory time constant is 0.6 to 0.8 seconds. If it's less than 0.6, you have stiff lungs, and the most common thing you'll come across is ARDS. You might have a patient with an abdomen out here, ileus. They might have a very stiff chest wall from something like angst-spond, or they might have chest trauma or something. And then if it's greater than 0.8 seconds, you either got a very high compliance, so you've got a baggy pair of lungs, so COPD, so the lungs are emptying, they're going, yep, or there's a resistance problem, or there's an airflow problem. So the patient might have asthma, so they're breathing out like that. You would have seen that clinically, or they might just bite their ET tube. And the ASV station this afternoon, I'll show you, we can demonstrate this. And then the IE, so in the passive patient, the IE ratio is calculated from the time constant, okay? So it'll say if the time constant is this, give an IE ratio of this. If the time constant equals this, give an IE ratio of that. And that's just a pure computer algorithm. So minute volume, respiratory rate times tidal volume. So the expiratory time constant is inversely proportional to your respiratory rate. So if you have a low time constant, so stiff set of lungs, you'll have a high respiratory rate, and then so if that is set, if that's high, that'll automatically be low. Okay? So it automatically, in ARDS patients, gives you a low tidal volume. If your time constant is high, you'll have a low respiratory rate and you get a high tidal volume. With the low respiratory rate, one of the features, this prevents gas trapping. Yeah. These are the buttons that you control. So the minute volume. So in the passive patient, if you have a high CO2, you just increase this. If you have a low CO2, you just decrease it. PEEP, we'll talk about this, the PV tool, hopefully. Setting PEEP's quite tricky. We have some easy bedside ways of doing this, but it's not always that straightforward. And the PV tools will help this. And then your FiO2. We have a lot of patients on 21%, and this is our target saturation. Whether this is right or not, I don't know, but this is what we do. So the expiratory time constant, it's a passive process. It's how quickly the lungs empty. So the expiratory time constant is a passive process, and it's how quickly the lungs empty. It's measured in seconds, and it's influenced by the airways resistance. So you imagine sort of just blowing out through your mouth like this. It's quite quick and easy. You try and blow out through a straw. It's tricky, isn't it? Yep. And you probably need a higher pressure to get the same volume out. And then the elastic recoil of the chest wall and the lungs, yeah? So you imagine a really stiff balloon, it's going to go boom. You imagine a big floppy COPD pair of lungs, it's going to go brrr. Yep. For what it's worth, so it's a natural log of decay. So after one time constant, 30% of your original volume left in your lung is gone. After two time constants, 37%, thanks very much. 37% of that's gone. And essentially what it tells you is roughly after 3 time constants, you will have breathed out. As I said this earlier, the expiratory time constant is virtually proportional to your respiratory rate. So in COPD, they'll have a high time constant, low respiratory rate, and then have a low time constant, high respiratory rate in ARDS. So I'm just going to try and show you here. So here's the pressure curve. So this is inspiration here, and this is expiration here. So the line along here is seconds, and this is flow. Sorry, it's in French, but I borrowed some of the slides from France. And it's essentially how quickly this happens here. This is your expiratory time constant. So if you look at the next, so this is a normal expiratory time constant, 0.6 to 0.8 seconds. You see it here. If you look here, this is a short time constant. It happens a lot more quickly compared to this. So if we take this as seconds, or there's two blocks here, this is sort of 1.5, yeah? So this is a restrictive defect. Then what you can see, so most patients, normal patients you put on a ventilator, you'll see a compliance of about 60. The inspiratory resistance is usually less than 10, is what I quote. If you've got someone who's stiff lungs, so if the compliance is below 40, they tend to be stiffer, normal resistance. And then if you look at the COPD patient, so you see the flow rates are a lot lower, but they take a long time to breathe out, yeah? So to compliance normal, the resistance is up, okay? So the area under here is all the same, yep, as if you're breathing out 500 mils, yep. But the two things which will change, so COPD or asthma, you classically have a lower flow rate. We know this from peak flows, yep. But it takes a lot longer for them to breathe out. So clinically, you see these guys, like lean forward and they're breathing out like this. The ARDS and pneumonias, so the tidal volumes go down, they're quite sort of puffy, aren't they? And here's just sort of, this is one of the, who uses this screen? Like the pictures? Again, this is just computerization of stuff. So what it does, so there's low time constant here. So the time constant's low, the lung shape changes. You get square lungs, yeah? If the compliance is normal, you get nice curvy lungs. If the resistance is high, this tree goes red, yeah? This is a nice, easy, quick way of saying, all right, you come along and go, right, you say, oh, the time constant's low. So is there resistance or a compliance problem? Or most of the time it's a compliance problem. The patients that are a bit tricky sometimes, if your time constant's high, you don't know if you've got a COPD patient who's got normal airflow, and just looking at this screen will tell you whether you've got a very, very compliant set of lungs or whether there's a resistance problem. The COPD patients, we hardly ventilate any of these now. I don't know clinically what you find. They all get non-invasive, don't they? The COPD patients you see is usually the ones that are post-op. Yep. Their inspiratory pressures tend to be quite low. It's like inspiratory pressure is about 10. But their time constant tends to be quite high, and their tidal volume is a little bit higher as well. So in the passive patient, so this is the patient who's paralysed. So you set the minute volume on the ventilator. This is your minute volume, percentage minute volume. The respiratory rate, so the time constant is measured. And then because you know these two things here, the tidal volume, the pressure control is automatically adjusted to give you this tidal volume that's required. This is how the closed loop works. And it varies from breath to breath, yeah? The active patient, so the spontaneously breathing patient, this is a little bit more tricky. I think a lot of people struggle to understand ASV because of this. So the minute volume, the patient decides this. The patient says, I'm in pain, I'm asleep, I want to breathe at a certain rate. The respiratory rate, the patient decides this themselves as well. Obviously, this is thrown into their lung mechanics, the time constant. The IE ratio, the patient decides. And then the other thing is the tidal volume. The ventilator will automatically adjust the pressure support to give you the tidal volume. Okay? Again, the caveat, sometimes these patients, the muscles are not so good. Remember the slide I showed right in the beginning, the work of the muscles? And sometimes the muscles are not so good, so you end up with a situation where the patient has a very high minute volume, the respiratory rate is quite high, and the tidal volume is not so great. You then come along and you increase the percentage minute volume, and this is a way of artificially giving them more pressure support. Yeah. So your pressure support wean, it'll do this. Yeah. Then you just leave them, and with time, you see the respiratory rate come down, tidal volume go up, and then as the lungs get better, they get more strong. The ventilator itself will automatically wean the pressure support. Okay. So that again, pre-Hamilton, we used to do this. Reduce pressure support by 1 every 12 hours or something. Yep, the ventilator automatically does this now for us. Oh, sorry, next. So, percentage minute volume button. So in the passive patient, so the paralysed patient, or fully sedated, not interacting with the ventilator at all, if the CO2 is high, you just increase the minute volume. If it's low, you decrease it. If the patient has a very high work of breathing, so the minute volume is perhaps 2 to 3 times their resting rate, we will increase the percentage minute volume. This gives them more pressure support. And I'll show you this in my demonstration this afternoon. And the range of this button is 25 to 300. If you want to do a sort of spontaneously breathing trial, which is very easy to do, you can put this button down to 25%, and this will give the patient 5 of pressure support. Yeah. Only do this for 30 minutes, you don't want to tire them out, yeah? And typically, the range of minute volume that we use is 70 to 200, yeah? This is what the IntelliVent range is, and this is what we tend to use. So, this is the same lady I had last week. So, 78-year-old female, she's previous healthy, couple of grandkids, I think just on AdCal, presented with breathing difficulties. How are we going to put her on the ventilator? Adult, female, she's 170 tall, 62. Got to use ideal body weight. I think most people are doing this anyway. Yeah. I see different hospitals measuring ulnar length, As soon as the guys come in, we get a tape measure out. And that gets entered in the computer system, and all our medications, nutrition, it's all based on ideal weight as well. Again, that's a bit more controversial. But what we can see here is when you get fat, your lungs don't get fat. Yep. So you have to use ideal weight. You often see, this patient weighs 200 kgs and their ideal weight's 50. They'll go, but you have to do it. Some to just do, again, the daily check at the bedside. So you click on the patient button. We just make sure it's still female. I've changed. She's grown. Well spotted. And then click in modes. So down the side here, these are essentially volume type modes. These are more pressure. You choose ASV. And then the buttons, these are the control buttons that you use. So I've got this patient on IntelliVent for what it's worth. But the buttons you adjust are the minute volume button, which I've talked about, the PEEP and the FiO2. The PASV limit. So this is defaulted to 30. So what it means is that the pressure gets to 30, flow will stop into the patient, yeah? It's just a safety feature. And this is defaulted to 30 most of the time. Sometimes if you've got a bad AODS and we're on PEEP of 20, 25, we'll put this up to 40 and we keep an eye on the delta P. Then these three buttons here are only active when the patient's spontaneously breathing. Okay? So flow trigger, we use flow, you can use pressure if you want. The ramp speed, this is how fast the air blows into the lungs. Again, I'm not sure. We default to 50, whether this is right or not, I don't know. It seems to work most of the time. And the expiratory time switch. So this means when you get to 30% of the initial inspiratory flow, the ventilator cycles to expiration. Again, this is defaulted to 30 most of the time. Most of our patients are normal, have ARDS lungs. If you had a patient with bad COPD or asthma, I'd probably put this up a little bit. Just it makes it more comfortable for them to breathe. Here are the alarms here. So pressure, minute volume. So the pressure here is 40. So the ASV limit is always 10 below the pressure limit. Rate, tidal volume. I keep on asking Hamilton to get rid of the actual volume and just do it in mils per kg. I think it makes more sense. Then you set these appropriately, and then off you go. I've talked about these are the parameters that we feel are important, and we've trended them here as well. So I'll just put this picture in here. So PV tool, we'll talk about it. This is what we want. Again, there's 3 million of these buggers, and it's difficult to know where you are. So if you like this, you can imagine it's difficult to blow them up. If it's full of fluid, again, you won't get gas exchange. So everyone familiar with this graph here? This picture, the ASV graph? So tidal volume, respiratory rate. This is the minute volume here. And then you have your box of safety. The red box you can't really see. You just put the background on it. Oh, you see it on a different slide. But anyway, this box, the boundaries of this box is determined by 4 different things. Okay? So the bottom is 4.4 times the ideal weight that you put in. So the only way you'll adjust the height of this lower part of the square is to adjust the patient's height. Yep. And this is just to avoid dead space ventilation. Okay. 4.4 is probably a little bit too much, but this is what the algorithm is. The top of the box, what determines the top of the box is 3 things. So it's 1.5 times your high tidal volume limit. So if you set your tidal volume limit at 1 litre, if you get a tidal volume of 1.5 litres, flow will stop. It's also 22 times the ideal body weight, so 70 kgs. This is about 1.5 litres as well. So if you get above this, the flow will stop. But the thing which affects the top of this box, whether it sits up here or whether it sits up here the most, is the PASV limit multiplied by the static compliance. Okay? So if your lung gets stiffer, you'll have a set number multiplied by a smaller number. So that means the top of your box goes down. Okay? If you have a bad COPD patient, so the compliance is high, the top of the box will go up. The next slide shows you the different shapes of the box. This boundary here is determined, this is to prevent gas trapping. So it's minute volume divided by tidal volume. Just forget that. The easy one to understand probably is 20 divided by your time constant, okay? So if you imagine a patient with a stiff ARDS, so 20 divided by, say, 0.3, the box will be right over here, okay? So it allows higher respiratory rates. If you imagine a patient with a high time constant, so COPD, so say the time constant is 2 seconds, you have 20 divided by 2, so it means the border will be over here, and this gives the patient a lower respiratory rate. If the patient has a low respiratory rate, you're less likely to get gas trapping. And then the last box here is 5. This is just to stop you getting a tidal volume of 7 litres and 1 breath a minute. This maybe should be 8, but 5 is what's been set. So you can see the square now. So if I come along just on the edge of the bed, I can see the lung mechanics look okay. If I see a patient with this, so this is COPD, asthma, or ET block, okay? So I'll then go to remember I showed you the lung picture? I'll put that on, and it tells me what the compliance is, what the resistance is. I might just put a suction catheter down. If that doesn't go down very well, maybe the patient's just put in the ET tube, and this pushes the resistance up. This is easy to remedy. Or I listen to the chest, I hear lots of wheeze. I know from the clinical history the patient's got asthma. This is why it's given it this shape. I had a 15-month in status the other day, and the shape of this box changed. So 10 kgs changed like this. They had a size 4 tube in. It was just secretions. So as soon as you suck them out, the box went back to this. Yeah. So the lung mechanics, they change all the time. And then this is ARDS. Yeah. So if you see a long flat box like this, think you've got a stiff respiratory system. Does that help? Yep. So when to extubate? Guys use this one as well? Yep. So there's 3 sections. So the patient's got to be sitting there going, the pathology is better. Sitting there going, that helps. So they're nice and strong, they've had good physio. But this is essentially, oh, sorry. That's my fault. So this is essentially divided into 3. So oxygenation, and the 2 bits you look at are FiO2. So if they're between 21 and 40%, they're probably okay. If the PEEP is between 0 and 8, they're probably extubatable. So if these discs are in here, the oxygenation is probably all right. Yeah. CO2 elimination. So the important bits are here, is what is their resting minute volume. If this is too high, if they're working hard, taking the tube out, they'll struggle. And then this here is the pressure support the patient requires to give them the tidal volume. Again, if this is high, this will tell me that the system is probably stiff as well. Yeah. And then lastly, so the column on the end here is spontaneous activity. So this patient's not breathing. You want 100% spontaneous activity. There's no point taking the tube out otherwise. And then this column here, you can put various things in here. So this one shows P01. So this is the negative pressure they generate in the first 0.1 seconds. So if a patient's going, they're working hard, then you're not going to extubate them. You can use rapid shallow breathing index, etc. and whatnot. This is all configurable. You can put in here what you do. I think we use rapid shallow breathing at the moment. So if all these discs are in these boxes here, pathology is better and the patient's going, you're probably all right to extubate, yeah? So, ARDS, the time constant's low, so the tidal volume will be low. This is good. If you've got a very, very stiff system, this can be a problem. And you sometimes have to, prone them, frusemide them, whatever, just to make the lungs better. But sometimes with the very, very stiff ARDS, you have to use other manoeuvres if your PASV limit's high. COPD, the time constant's high. This will give you a high tidal volume. I know a lot of people are uncomfortable with this. How you prove this in research would be quite tricky. But I don't, thankfully this is not or for us it's not a massive patient group at the moment. If people are uncomfortable, what some people have been doing is reducing the PASV limit. Post-op, patients usually have a normal time constant, and ASV will give you tidal volumes usually pretty fine. And then asthma, resistance is high, so your time constants will be high, your tidal volume's high, your PASV limit can be a problem. Again, thankfully asthma, we don't ventilate many of these nowadays. I think the control in the community is a lot better. And we've also got things like adrenaline infusion, salbutamol, magnesium, etc. This means you don't have to get stuck with them on a ventilator. I'm just going to couple of other concepts which perhaps might make a difference. This is a real difficult concept to explain. I don't know if this will do it for you, but anyway. So if we have an expanded lung, I'll put 7 mils per kg. Most people accept this now, yeah? So you imagine a situation where half the lung has collapsed, and you're still on, say, a volume control mode. You see what happens? It's difficult to prove this exactly, but you can see how this problem arises potentially, yeah? So whole lung is expanded, 7 mils per kg, it's fine. And we see this. The delta P tends to be fine, the peak pressure is not so bad. You get collapse. Collapse is, we diagnose this chest x-ray, listen to the lung bases, ultrasound the lungs, we can see collapse, yeah? But if you're on the same tidal volume, you're potentially overextending these lung bits here, yeah? This is what we teach in our unit, again, for what it's worth. So again, it's not 100% foolproof, but it's an easy way of sort of helping out. So to diagnose shunt, so if you've got lung collapse, just on the ventilator there's a button to give 100% oxygen. If the sats don't change at all, you've probably got a shunt, you've probably got collapsed lung somewhere, yeah? And then the other thing we do is we have a calculation on our blood gas on the computer screen, which essentially just subtracts the PaCO2 from the end tidal CO2, yeah? If this is greater than 2 kilopascals, we start thinking, well, maybe we've got some dead space. So do we have regions of lung which are collapsed down and regions of lung which are overdistended? Yep. These, you can do these in a few seconds. You need a blood gas to do it, which is a bit of a pain, but you can. So what are we trying to achieve? Open the lung, match ventilation perfusion, alter the minute volume, and saturation end tidal CO2. Just most of the time it tells you tells you how you're doing pretty much straight away. And then we've always got this thing as well, we mustn't damage the lungs. So main diagnosis has to be pathology. And I think one of the first slides I put up, so the work of the muscles against the elastic recoil of chest wall and lungs, and then the resistance. You've always got to look at that equation and say, right, have I got a pneumonia? Are the lungs stiff? Have I got pulmonary edema? The lungs are stiff. Just try and work out where along there the problems are, fix that, and then you can fiddle with the ventilator. And then the other thing which is also very interesting for me, and this is why I think mechanical closed loop is important. So if you have a respiratory rate of 20, just multiply it up. That's almost 29,000 breaths in a day. You're going to want to sit there changing it every few minutes? Yeah, it's a waste of our time, isn't it? Why not use a system which adjusts to the resistance and compliance? Yeah. Patient factors. This is something else which is obviously not talked about, the compliance, so the chest wall, the lung resistance, and whether the patient's breathing or not. So sometimes you've paralysed them and ventilation is a piece of cake. They start waking up and interacting with the ventilator. It becomes a nightmare. These change all the flipping time. Yep. You might have a little bit of secretion. Your resistance goes up. Yeah. If you're on a fixed pressure mode, your tidal volume is going to go all over the place.